We're just going to give it another minute just to let a few more people join, and then we'll get started. All right. It's a couple minutes after 12:30, so I think we'll go ahead and get started. Hi, everybody. My name is Elizabeth Vaith, and I'm the Antibiotic Resistance Epidemiology Program Administrator for the Maryland Department of Health. On behalf of my colleagues here at MDH, I want to welcome you to today's webinar entitled The Other C Words, the Battle Against Multidrug-Resistant Organisms. We're in this together. We here at MDH have been working with our colleagues at DC Health and the Virginia Department of Health, and with subject matter experts at the Centers for Disease Control and Prevention to put together this webinar with the goal of bringing attention to a problem that's really affecting every healthcare facility in the Mid-Atlantic region right now, and that's the spread of multidrug-resistant organisms. So we're really excited to have you all here because this is truly a problem that will require everyone to work together if we want to succeed in the battle against these organisms. So with that, I'm going to pass things off to Jackie Rubin in DC to introduce herself.
My name is Jackie Rubin, and I'm an epidemiologist with the DC Health HAI program. And on behalf of my colleagues at DC Health, we'd like to welcome you to this kickoff webinar. We really do look forward to the discussion today and the continued regional collaboration in addressing MDROs. So thank you, and pass it on to Shana.
Good afternoon, everyone. My name is Shana Bernard, and I am the Antimicrobial Resistance Coordinator for the Virginia Department of Health. On behalf of myself and my colleagues at VDH, I would also like to welcome everyone today. I also have the pleasure of introducing our CDC speakers that will be presenting some great information. So first, we have Dr. Elizabeth Soda, who is an infectious diseases physician who started her career in public health as a hospital epidemiologist before joining the CDC. Since joining the CDC, she worked with the Illinois Department of Public Health to help with the response to multidrug-resistant organisms before moving to the antimicrobial resistance team with CDC's Division of Healthcare Quality Promotion in Atlanta. Our next speaker is Caitlin Forsberg, who is an epidemiologist at the CDC Mycotic Diseases Branch. Her work focuses on drug resistance in Canada, including the national response to Candida auris, whose global antimicrobial resistance surveillance system, also known as GLASS, and the AR Lab network. And finally, we have Dr. Heather Jones, who is a doctoral prepared nurse practitioner with a clinical background in long-term care, acute care, and chronic care management. She is a nurse consultant with the long-term care team within CDC's Division of Healthcare Quality Promotion with a strong focus on infection prevention and control. And you can go to the next slide where we have a few housekeeping items before we get started. So we're going to ask that you please edit your name to include your name, your facility's name, and the state or district your facility is located in, so we know where you're coming from, since we do have multiple states and jurisdictions here. You can change this in Zoom by selecting participants on the right-hand side, hover your mouse over where your name is, and then just click on the option to rename and change your name, and then hit OK. And on this slide, there is a screenshot of what that will look like. So we thank you in advance of doing that. In addition, all participants are in listen mode only, and the chat box has been disabled, but please enter questions in the Q&A box, and they will be addressed at the end or during the presentation by the speakers if applicable. If we are not able to get to all the questions, we will capture and respond to you directly. Thank you, and I will now pass it over to our first speaker, Elizabeth.
Thank you so much, Shana. And I want to thank all of you for allowing me to spend some time with you today, and a very warm welcome to our first webinar on a series focused on multidrug-resistant organisms, or MDROs. I'm actually going to go ahead and stop my video just to make sure that I have enough Wi-Fi to get through this whole talk. So I will be back on in a little bit. So as mentioned, the Mid-Atlantic region is currently seeing the emergence and rise of several different types of MDROs. So we really find ourselves at the ideal time to come together as healthcare professionals in Virginia, Maryland, and DC, and several other facilities from a couple nearby states to help limit their spread. You may be asking, why are we targeting you for this webinar? Well, for one, this area of the Mid-Atlantic is unique, and that's not just because of your very tasty food or your abundance of history, but also because you have many large urban areas within close proximity to one another. This allows for the frequent transfer of patients and residents, along with the opportunity for MDROs to transfer along with them. Second, as mentioned, the Mid-Atlantic has an MDRO problem, including both a highly drug-resistant fungus called Candida auris and several drug-resistant bacteria. So ultimately, it's going to be up to all of us within public health and healthcare systems to try to stop the further spread of these organisms. Whether your facility is currently caring for people with these MDROs, has cared for them in the past, or is yet to care for them. Our objectives today are quite simple. First, we're going to try to give you a break from COVID and minimize most discussion about it. However, I will fully acknowledge MDROs and COVID are not completely separate topics and impact each other. Second, we want to bring together a group of healthcare professionals from both the long-term care and acute care settings from different jurisdictions to hear the same message and work towards a common goal. And last, today's webinar is really meant to help set a foundation of knowledge, which we will continue to build upon in future webinars down the line. But before we dive in, I want to take a moment to thank all of you for your continued bravery and sacrifice during this pandemic. You have both saved lives and comforted those in their last moments, and we all owe you a great deal of gratitude for your work. So what are MDROs in the first place? This term typically refers to bacteria or fungi that are resistant to all or most of the available antimicrobials, which of course makes them hard to treat if you end up with an infection due to one of them. The term MDRO is actually an umbrella term, which covers many different types of germs, some of which you may be very familiar with, such as MRSA or VRE. However, the ones that we'll be focused on today may be ones that you're less familiar with. These are the MDROs that we often describe as emerging MDROs, and are what I'm referring to whenever I use the term MDRO moving forward. So where did these MDROs come from in the first place? To make a very complex story simple, germs are exposed to antimicrobials that are out to destroy them all the time in people, animals, and our environment. To defend themselves, they can develop or acquire ways to resist these antimicrobials. Some of this resistance can be spread with their progeny, like a family cell phone plan is, but sometimes the resistance is also shared by jumping between different germ types, so more like a friends and family plan. And then ultimately, these resistant genes can be passed on or transmitted primarily in healthcare facilities from one person to another or from the environment to a person. And we help the germs transmit when infection control practices such as hand hygiene or environmental cleaning and disinfection are not fully practiced. In addition, these MDROs tend to affect the sickest people, like the ones who require multiple and often prolonged healthcare stays, have invasive devices, are ventilator dependent, or recently received broad spectrum antibiotics or antifungals. MDROs can cause many different and serious infections, such as those of the bloodstream, and can result in worse outcomes, resulting in longer hospital stays and higher mortality. But some people may not have any signs or symptoms of an infection, but can still have the MDRO living on or inside of them. This is called colonization. Some of these colonized people will go on to develop an infection, but there are many more people colonized than infected people out there. So in other words, the infected people we do see are really just the tip of the iceberg, while the number of colonized people among us is much higher and who can't easily be seen. And this is a really important concept, because colonized people can pass the MDRO they're carrying to other people or their environment. And unlike people who are infected, we may not be applying the same infection control actions, such as the use of gowns and gloves during their care. And unfortunately, colonization can last for a very long time. And while some people may eventually become decolonized, they may just as easily become recolonized again. It is for these reasons that we don't tend to recommend retesting someone for colonization status once you know they're already colonized. And despite being an area of great interest, currently there are no well-established decolonization strategies for the MDROs we're discussing today. On that note, we're now going to discuss the MDRO, Candida auris or C. auris, in more detail, and I'll hand it off to my colleague, Caitlin.
Thanks. I first wanted to go over why we're so concerned about Candida auris, which is this emerging yeast. It's very different from other kind of Candida species. First, because it's highly drug resistant and actually acts a lot like a drug resistant bacteria. So it can colonize the skin, as Dr. Soto was just talking about, and lead to invasive infections. It can also colonize or contaminate a person's environment and spread very easily in healthcare settings. Next slide, please. This is a look at our C. auris cases over the years in the United States. You can see that while they've been increasing for a while, we've seen an even further increase during COVID. And this is both among clinical cases and screening cases. A clinical case is when you have a positive C. auris specimen collected as part of routine clinical care. And a screening case is when you have a positive swab that was collected specifically to assess if a patient has had C. auris colonization. Recently, we've also seen more links or more cases without links to other known cases or abroad, which is concerning because this may mean that there's more transmission occurring that we haven't detected yet. We've also seen outbreaks happening in areas that have previously had cases but were well contained. And we suspect that some of these increases lately are related to COVID-related changes in routine infection control, things like PPE conservation strategies, extended gown use, cohorting, etc. Next slide, please. You can see that what was happening nationally is also playing out here in the Mid-Atlantic region, where both clinical cases and screening cases have been increasing over time and are particularly high during this 2021 year so far. I also wanted to pay particular attention to resistance in C. auris. So here I'm showing the C. auris resistant isolates that we've collected in the AR laboratory network in DC, Maryland, and Virginia. For Canada, unfortunately, there's only 3 major antifungal drug classes, so this is a lot different than bacteria. And unfortunately, Candida auris could be resistant to all of them. So here in the DC, Maryland, and Virginia area, you can see that 99% of isolates were resistant to azoles, 64% were resistant to polyenes or amphotericin B, and about 4% were resistant to echinocandins. Even more concerning, we saw 65% of them were multidrug resistant. So this means they're resistant to at least 2 of these drug classes. And we've also seen multiple pan-resistant cases reported since 2020 and an increase in pan resistance lately. Next slide. In fact, unfortunately, the Mid-Atlantic is one of the 2 areas of the country that is now experiencing transmission of echinocandin resistance for the first time that's been seen in the United States. Echinocandins are the first-line treatment against Candida auris, which is why we want to be especially aggressive in infection prevention and containment here in the Mid-Atlantic. Thank you.
Thanks, Katie. The next group of MDROs we'll be discussing broadly fall under the term carbapenemase-producing organisms, or CPOs. The carbapenems are broad-spectrum antibiotics, such as meropenem, that are used to treat a wide range of infections. Carbapenemases are enzymes that destroy not only the carbapenem antibiotics, but other antibiotics from the same beta-lactam antibiotic class, which contain many of my personal favorites, like zosyn or ceftriaxone. In addition, bacteria with these carbapenemase enzymes can also harbor resistance to other important classes of antibiotics, leaving little or no antibiotics left to treat them at all. You probably already know many of the different carbapenemase enzymes by their 3-letter abbreviations, such as KPC or NDM. Bacteria that make these enzymes are called carbapenemase-producing organisms, or CPOs. Some bacteria are more commonly carbapenemase producers, such as E. coli or Klebsiella pneumoniae, who are members of the Enterobacterales order, and thus they would be considered a CP, or carbapenemase-producing, CRE, carbapenem-resistant Enterobacterales. Other bacteria you may have heard of include CP crab, or carbapenem-resistant Acinetobacter baumannii, and CP-CRPA, or carbapenem-resistant Pseudomonas aeruginosa. So why do we care about these bacteria? Well, not only are they highly drug resistant, but as I discussed earlier, they can share how to make these enzymes with other bacteria, which means this resistance can spread rapidly. As an example of how quickly, since the first identification of KPC-CRE in 2 US states in 2001, KPC-CRE has spread to all 50 states, the District of Columbia, and Puerto Rico in just 16 years. And now we're seeing the concerning rise of other carbapentamases. For example, here in the Mid-Atlantic region, we have seen the rise of both NDM-CRE and NDM-CRAB in healthcare facilities. For the sake of time, I will not elaborate further on the CPOs, but we do hope you'll join us on a future webinar to talk more about this issue. So let's next turn our focus to the role that healthcare facilities can play in the spread of MDROs. The healthcare ecosystem consists of many different types of healthcare facilities and providers who are all part of a very intricate network of patients or residents who share. And as such, what one facility does or does not do has an effect on the whole region. Over the next several slides, I'll go into more detail on the role different types of healthcare facilities play in this process. I want to begin with healthcare facilities that we call high acuity post-acute care facilities, such as long-term acute care hospitals or LTACs and ventilator-capable skilled nursing facilities or VSNFs. These facilities care for the very sick, many of whom have many risk factors for MDROs and who require long durations of care. And while they play a critical role in serving individuals within our healthcare system, they're also prone to higher rates of MDRO outbreaks compared to other healthcare facility types. However, this also means that they have the opportunity to play a large role in limiting the spread of MDROs throughout a region. We have seen some powerful initiatives by some of these facilities to include here in this region to provide excellent care to the patients and residents with MDROs who are working to prevent the spread to other people. Now, in comparison, most short-stay acute care hospitals will tend to see less MDR transmission within their facilities, likely in part due to shorter lengths of stay and often longer established infection prevention and control programs. However, that is not to say that they are immune to outbreaks either. Acute care hospitals do, however, tend to identify more individuals with MDROs, as they often acquire many cultures as part of routine care. Thus, they play such a key role in ensuring communication of a patient's identified MDRO status to public health and other healthcare facilities and providers. And due to their infection control expertise, they can also be powerful leaders in regional initiatives when they're willing to partner with other facilities in their region. There are also many other healthcare facilities and providers, such as lower acuity long-term care facilities who do not care for ventilated patients, outpatient clinics, home health agencies, and medical transport companies. Well, again, they are less likely to experience large outbreaks. They are also still not immune to them. And they can still have negative impact on the spread of MDROs if they don't understand what MDROs are, if they're not communicating well with other providers, and if they have poor infection control practices. So I hope I showed you how we all can play a role in limiting MDRO spread. However, sometimes facilities can fall into the blame game trap, blaming other facilities for what is going on in their region or even within their own walls. However, like all blame game traps, this is counterproductive for them, their patients or residents, and all the other healthcare facilities around them. So instead, I would argue that we need to accept that these MDROs are here, that they can affect any healthcare facility, and that we need to focus our energy on working together. And you don't have to just take my word for it. This is the view the general public and press often take as well. Some of you may have read a series of articles published by the New York Times back in 2019, describing how Candida auris moved through both hospitals and nursing homes in New York and in Chicago, and underscored the responsibility that healthcare facilities and public health departments have in stopping its spread. So what can we as healthcare professionals do to help prevent the further spread of MDROs in the Mid-Atlantic region? Before we start on this topic, I want to share with you a story from my time working with the Illinois and Chicago Departments of Public Health. For some of you listening, you may have had firsthand experience with how Candida auris can spread through a facility, but for those of you who haven't, this may be eye-opening. This slide shows you one purple dot representing only one person with Candida auris in a VSNF in Chicago in March of 2017. And this is the same VSNF just 10 short months later. As you can see, there are now many more purple dots, And in fact, that translated into 43% of their residents on their ventilator unit with Candida auris. And eventually Candida auris spread even beyond their ventilator unit as well. And to make another important point, this facility didn't just have Candida auris. The other color dots represent the different types of CPOs the facility had, to include KPC, NDM, and VEM. And many residents had more than one of these MDROs. This is called co-colonization and is quite common. Co-colonization is important to remember because often facilities only want to look for one type of MDRO at a time, but hopefully you can see the problem with that, especially if you have to room people together or cohort them. For instance, by only looking for Candida auris, you may accidentally room someone only with Candida auris, with someone who actually has both Candida auris and NDM, potentially spreading NDM to the previously negative roommate, which is not good for the patient or resident and can rapidly make your facility's MDRO problems worse. And I can assure you that this is not the only facility with an MDRO problem in Illinois. For instance, Candida auris has affected all types of healthcare facilities across the state, with a recent count of over 1,400 individuals with C. auris. And due to patient and resident transfer networks, it has spread well beyond Chicago, throughout the state, and to other neighboring states. So then how do we limit MDRO spread across healthcare facilities in the region? Well, it's quite simple and can be summarized in 3 steps. Step 1, healthcare facilities and health departments should work together to identify as many infected or colonized people as possible. Step 2, healthcare facilities should establish good baseline infection control practices and additionally use the recommended practices for people infected or colonized with MDROs. And lastly, ensure that someone's MDRO status is communicated anytime they transfer to another healthcare facility. But if only it was that simple. Here's just a small sample of the many concerns and problems that have been expressed to us from all over the country when it comes to MDROs and these steps. For example, facilities that have identified individuals with these MDROs may have issues with acceptance of their patients at transfer. And likewise, similarly, people express concerns that if they look for the MDROs among their patients or residents and find them, it could hurt their reputation and cost them money and time. So it's just better not to look. Or there are facilities that really want to improve their infection control programs. They're not being provided with enough resources to build a robust infection control program. Or there are facilities that are having issues with communication with other facilities about which patients or residents are known to have MDROs at transfer. Or simply facilities not realizing how important they really are in helping to solve a region's MDROs problems. That it really matters less where someone acquired the MDRO, but more importantly, what are the next steps that are needed to prevent further spread, both within their facility and the facilities they share patients or residents with. So instead, I want to acknowledge that while simple in theory, it can be quite complicated in practice. However, again, I would argue that it can be simpler if we work together in a coordinated and complementary manner with the common goal of implementing the 3 steps together. For the sake of time, we'll only briefly highlight the 3 steps today, with future webinars providing more in-depth background. As we walk through the different steps, I want to highlight some common terminology that we'll be using. When I say all facilities, this will typically refer to an activity that all facilities listening could be asked to engage in by their health departments, compared to some facilities, which are activities that will only apply to some of the facilities listening. And if they have not already, your health department will be in touch if they believe your facility may benefit from these activities. And lastly, if you see this picture, it means that we'll be sharing a success story about how a facility successfully implemented and used the identified activity. So again, step 1 is to identify those who are infected or colonized with MDROs. Because the more people we know who have an MDRO in our healthcare systems, the more precautions we can take to stop the MDRO from spreading to others. One way to identify people with MDROs is through the use of clinical cultures. A clinical culture is one that is obtained as part of routine care. So it's very important for all facilities to understand which MDROs your laboratories can or cannot identify. For instance, many laboratories can identify carbapenem-resistant organisms, but may not be able to tell you if it's a carbapenem-based producer or a CPO. Likewise, there can be some complexities around Candida auris identification, which will be a topic of a future webinar. In addition, you and your laboratory should follow your jurisdiction's reporting and isolate submission guidelines. And all of this is true even if you're using a contracted laboratory. Now, for some facilities, they may want to consider identifying all Candida species isolated from any laboratory culture. For instance, many laboratories will just identify Candida species and not the type of Candida from non-sterile body sites such as urine. However, a facility could increase their ability to detect Candida auris if their laboratory was able to expand their identification to these non-sterile sites. And Katie will now give you an example of how this practice helped other facilities with a success story. Katie?
I wanted to tell the story of a lab serving long-term acute care hospitals in Orange County, California, that began performing species identification on urine specimens as an early detection measure for Candida auris. Within just 5 months of them starting to do this, they found Southern California's first ever C. auris case. And that jump-started screening at other high-risk facilities such as LTACs and VSNFs in the county, and 9 of 17 facilities were found to have cases. These facilities received infection control and prevention assessments and were able to successfully contain the outbreak. But the first bloodstream infection in the county wasn't identified until 3 months after that original urine positive was found. So C. auris prevention efforts would have been delayed 3 months if laboratory detection was solely focused on sterile body sites.
Thanks, Katie. In terms of identifying people who may be colonized with an MDRO, there are several ways to accomplish this, to include point prevalence surveys, or PPSs, emission screening, and discharge screening, all of which are considered types of colonization screening. The topic of colonization screening can be quite complex, but will be the topic of our next webinar. But for all of these methods, facilities collect a swab at different body sites, such as the axilla and groin for Candida auris and rectal swabs for most CPOs, which is then sent to a laboratory to see if they can identify the MDRO of interest. And if they do, then the person is considered colonized. I'm going to expand upon this topic by providing a high-level overview of these different types of colonization screening, beginning with a PPS. A PPS is a form of colonization screening performed at a single point in time on a number of people within a facility to see if they're colonized. There are really 2 types of PPSs. The first is a response PPS, conducted in response to the identification of someone with an MDRO, with the goal of identifying additional individuals within a facility for whom IPC actions are required. In addition, they can also suggest possible transmission within the facility itself. And it is to the facility's benefit to know if transmission is occurring within it in order to identify actions that need to be taken to prevent transmission in the future. Response PPSs can be utilized at all facilities, although whether or not they are used can depend upon several factors, such as how robust a facility's infection control program is, how many people with the MDRO are currently in the facility, or how common the MDRO is within a region. However, when used soon after detecting someone with an MDRO and accompanied by aggressive infection control improvements, they can be quite helpful. I'm going to tell you about another success story, and this one actually does come out of Illinois. As I showed you earlier, Candida auris can rapidly spread within healthcare facilities. However, I worked with a VSNF in Illinois who rapidly and aggressively responded to their first case of Candida auris. This included the immediate use of response PPSs to detect additional individuals colonized with both C. auris and CPOs, followed by immediate infection control actions to include the use of gowns and gloves, rooming people with live organisms together, and then assessing their overall current infection control practices. And they actually started some really great new ones, such as hand hygiene and environmental cleaning observations. Through both the use of response PPSs matched with good infection control that was really championed by their facility leadership, this facility that cares for the sickest of the sick was able to stop all further transmission while still caring for residents with these MDROs effectively. So besides response PPSs, the other type of PPS is something called a proactive type. And these are PPSs conducted at a facility regardless and sometimes even prior to the identification of someone with an MDRO. And they can be particularly helpful in healthcare facilities that are at highest risk for the transmission of these MDROs. Your health department can help you determine if this activity may benefit you and when. The hope with these proactive PPSs is instead of waiting for a signal, you're taking a more proactive approach to finding colonized individuals. This will allow for better detection and intervention, bringing benefit both to the facility and for the greater healthcare system. And if utilized early enough, it may allow you to catch an issue when it's just a small flame, as compared to a wildfire, where control can be much more difficult. As mentioned earlier, it does benefit the facility to look for more than one type of MDRO during these PBSs, depending upon the MDRO threats you're facing in the region. And now I'll ask Shana from the Virginia Department of Public Health to share a success story on proactive PBS.
Thanks, Elizabeth. Our story starts in June of 2020 when a hospital reported a case of Candida auris. At that time, that was the third case of C. auris in our state and the first in this particular region in Virginia. Our local health department started a public health investigation, which includes providing infection prevention recommendations, on-site visits, screening high-risk healthcare contacts, and retrospective and prospective lab surveillance for the healthcare facility that identified C. auris and also facilities the patient had been to in the previous few months, which we found included one nursing home. So we coordinated with the one hospital and the one nursing home. And fortunately, we did not find any additional cases, which on the surface, that is great. And we don't want to find any more cases. However, because our state had very few cases at the time, and there were really no epi-links to any other cases or international travel that could explain why this person had Candida auris, it really brought up the bigger concern that there is undetected spread occurring. So we consulted with CDC, and they recommended identifying high-risk facilities in the region, such as LTACs and VSNFs, to conduct proactive point prevalence surveys, even though our case had no connections to any of these types of facilities that we knew of. So we did identify one ventilator skilled nursing facility, and they were agreeable to screen the residents for Candida auris. There were also concerns about how shortages of PPE and conservation practices impacted the spread of other MDROs that were more common in the region, like carbapenemase producing organisms. So we also screened for CPOs in addition to Candida auris. We did end up finding some C. auris cases and numerous CPO cases that were not previously known about, and the local health department has been working with the facility on control measures. While we normally wouldn't call an instance where we found cases a success, the part I would like to highlight is just the proactive nature and the willingness of the facility to screen residents that weren't connected to any known cases at a time when that really wasn't typical of our public health investigation for these types of organisms. Our story is now being added to a growing number of similar stories from other states and jurisdictions that are finding when you proactively reach out to high-risk facilities in areas where cases are newly identified, we are finding undetected spread and are able to implement infection prevention and control measures much earlier than if we were to wait for a clinical isolate that is positive for Candida auris to be connected to the facility. And back to you, Elizabeth.
Thanks so much, Shana. And lastly, some facilities may also benefit from other types of colonization screening, such as those conducted either at admission or prior to discharge of certain individuals. As mentioned, these types of screenings will be discussed in more detail during our next webinar, although again, your health department can also help you determine if these activities may benefit you. So step 2 in our 3 steps is utilizing recommended IPC practices, and this will be covered by my colleague, Heather Jones. Heather?
Thank you, Elizabeth. So I will be discussing some of the recommended IPC practices that apply to all facilities that are listening today. These include 3 core strategies to limit the spread of MDROs, including hand hygiene, contact precautions for all facilities, or enhanced barrier precautions in nursing homes, which will be discussed briefly and then more in depth on a future webinar, as well as environmental cleaning and disinfection to include sink hygiene. Next slide. We will begin with hand hygiene. The preferred method is to use alcohol-based hand sanitizers in most clinical situations, as well as establishing and maintaining good hand hygiene observations by auditing and providing feedback to staff on their performance. This is essential to improving adherence to one of the most basic and effective means of infection prevention and control. Next slide. For acute care hospitals and long-term acute care hospitals that have patients with MDROs, contact precautions are the recommended transmission-based precautions to use. This precaution will also apply to certain nursing home residents, including those with Clostridium difficile, scabies, or norovirus. Otherwise, in nursing homes only, enhanced barrier precautions can often be applied to residents with certain MDROs. While private rooms are preferred for patients or residents requiring contact precautions, they are not required. If it is not possible for you to have private rooms for all the patients or residents requiring contact precautions, prioritize the private rooms for individuals with uncontainable secretions or excretions and cohort individuals with like organisms, which will be discussed further also on a future webinar. Patients on contact precautions should be restricted to their room except when movement is medically necessary. Enhanced barrier precautions, or EBP for short, are currently only recommended for nursing home use. EBP only requires the use of gown and gloves for high contact resident care activities such as dressing, bathing, and showering, toileting, providing hygiene, transferring, device care or use, and wound care. EBP instead of contact precautions should be used for most individuals infected or colonized with CRE, CRAB, CRPA, and Candida auris, and in addition should be used for any resident with wounds and or indwelling medical devices, regardless of their MDRO status, if they reside on a unit or wing with someone who is known to be infected or colonized with these MDROs also reside. If you have not already been using EBP in your facility and are interested in initiating, please contact your health department for additional tips. Many of us have been using COVID precautions for over a year now, so I wanted to provide a gentle reminder about standard precautions. Standard precautions are used in all settings and with all patients, not just the ones with known MDROs or other pathogens. It is in place to protect you and the patient or residents. Gloves should be worn at all times during patient interactions when touching blood or other bodily or mucous membranes and non-intact skin. Gowns should be worn during any procedure or patient care activity that may involve contact with blood, body fluids, secretions, or excretions, and during any activity likely to generate splashes or sprays with blood, body fluids, secretions, or excretions. The use of the mask, goggles, or face shield is also recommended during this time. We will now move to environmental cleaning and disinfection. When you think of cleaning, you must also think about disinfection, as both are critical steps in reducing and preventing the transmission of MDROs. This should include using EPA-approved cleaning and disinfection products or a product that does both at once, for at least daily cleaning and disinfection of high-touch surfaces, such as those pictured on the slide, including door handles, light switches, bedpans, toilet handholds. There should also be consistent cleaning and disinfecting of non-disposable, non-dedicated equipment after each use, including but not limited to vital sign machines, glucometers, portable radiology equipment, transfer and shower equipment. Along with knowing the right product to use, staff with cleaning responsibilities should know and understand the correct contact time for these products. A contact time is the amount of time a disinfectant must remain wet on a surface to be effective. Many products indicate various contact times based upon the germs it is targeted to kill. In most healthcare settings, it is often appropriate to use the longest contact time listed to ensure the disinfection of a wide variety of germs found in healthcare facilities. It is important to note that Candida auris requires specific cleaning and disinfection products. List P has EPA products with claims against C. auris and are the preferred agents for the disinfection. Also, currently, List P agents are effective against SARS-CoV-2, the virus responsible for COVID-19. If a List P product isn't available to you, then facilities could use a product from List K for registered antimicrobial products effective against C. diff spores. In addition, you may want to strongly consider using disinfectants that are effective against Candida auris, even if you have yet to identify an individual with it at your facility. This may be particularly important if multiple cases of Candida auris have already been identified in facilities that you frequently share patients or residents with. For the final portion, I would like to speak briefly on sink hygiene. Sinks and drains within healthcare facilities can become contaminated with MDROs. Thus, it is very important for your facility to remember the splash zones for sinks and drains, which is considered 3 feet on all sides, and they should not place items such as patient care equipment or medicines within the splash zones. In addition, all facilities are encouraged to develop a water management program to limit Legionella and other opportunistic pathogens from growing and spreading in their facilities. For more information about sink hygiene, please see the link at the bottom of the slide. And lastly, it is very important for all facilities to return to pre-COVID IPC practices when the situation and resources allow for it. For instance, instead of reusing or extending the use of gowns and gloves, facilities should return to the conventional practice of changing gloves and gowns after each patient or resident encounter, even if the patients or residents are housed in the same room. In addition, all gowns and gloves should be removed prior to leaving the room or prior to caring for another resident in a multi-unit room. Due to disinfectant wipe shortages, many were removed from the point of care, but with a return in supply, they should now be returned to the point of use, such as on nursing carts, Hoyer lifts, and vital sign machines. If you stop using disposable or dedicated patient equipment for those with an MDRO, perhaps this can now be reinstituted. Additionally, it is important to institute or reinstitute IPC observations and feedbacks of practice such as hand hygiene and environmental cleaning and disinfecting if that had to decrease due to COVID. And remember, some staff may require re-education on what conventional IPC practices were prior to COVID-19.
Thanks, Heather. And now on to our last step, communication. I think we all can agree that life is better in general with effective communication. And this also applies to when we transfer patients or residents either within the same facility or between a facility, a term called inter-facility communication. This knowledge of whether someone is colonized or infected with an MDRO should be shared at every transition of care to ensure that the appropriate IPC actions can be taken. In addition, if someone has a pending laboratory screening test, which is an outstanding result from a PPS at discharge, this should also be communicated to the accepting facility. Because in the end, this all boils down to the golden rule of giving what you wish to receive. But again, I can also acknowledge that effective MDRO communication can be a big challenge. Facilities may struggle with not knowing when or what or how to communicate this information, given that every facility may do something a little different from the next. In addition, knowing who to communicate with and knowing that the person on the receiving end of the information knows what to do with it can be very challenging. And lastly, healthcare facilities are very busy places. Without effective protocols and processes, this can make without effective protocols and processes, this makes communication harder. Thus, healthcare personnel just don't have the time to effectively communicate. However, by not effectively communicating, you are helping the MDROs win the battle, as illustrated on the slide, with the MDRO represented by a red dot moving its way through a healthcare network. So we all must take the responsibility to figure out how to improve this to protect our patients and residents in the region. Improving communication will be a topic of a future webinar, to include a talk by UCLA, who's effectively used both admission screening and their electronic health records to help with better communication within their own facility and at transfers to others. In addition, we'd like to hold a webinar that will be more of an open forum to hear from you all about communication. As part of this, we really encourage you to currently think about your communication practices to include both its strengths and weaknesses, and bring back to us ideas about what can be done to better facilitate this across all the jurisdictions. So I've thrown a lot of information at you. So what are the big take-home points? First, please be sure to understand your reporting and isolate submission rules based upon where your facility is located. The above links will provide you with more information if needed. Also like to mention there may be several facilities on here from Pennsylvania, New Jersey, and Rhode Island, and the slide deck also contains that information. Second, assess your current IPC practices and work on fixing identified gaps before you have a problem. This may include switching now to cleaning and disinfecting products with Candida auris activity. In addition, all of your health departments are skilled in providing facilities with free, non-regulatory IPC assessments to help determine where gaps may exist and help provide recommendations for improvements. The Virginia Department of Health has an online form where you can request assistance through the provided link. And while I know the world remains an uncertain place and we want to remain sensitive to that, it is important that facilities return to conventional pre-COVID IPC practices when the situation and resources allow. And third, please assess your current communication practices and consider attending our future webinars to provide us with your thoughts on how we can all work on improving communication. And last, please continue to educate yourself and staff about these topics. We will be providing you with a recording of this talk and the slides. We've included several additional educational links at the end of the presentation. Contact your health department if you're ever interested in more individualized training. And we also please strongly consider attending our future webinars. And here's just a list of some of the proposed future webinars that we could be covering with our next webinar, hopefully sometime in early November on colonization screening, but also helping to provide you with some information about laboratory identification, a little bit of deeper dive about the carbapenemase producing organisms. We could go deeper into IPC practices, enhanced barrier precautions for nursing homes, and a spotlight on communication practices. But in addition, we really do want to hear from you all. We'd love to be able to have some feedback sessions to us so we can hear about your challenges and we can work with you to help with some of that. Here are the educational links that I've mentioned. And this last slide includes contact information for the DC, Maryland, and Virginia health departments, as well as the Candida auris group and myself. I help cover MDROs besides Candida auris. Please, if you do reach out to CDC, make sure you also include your state health department in that email. And I want to end again with my sincerest thanks. I know you're very busy and you have many different competing priorities, but thank you so much for attending this webinar and helping us battle the MDROs together. So that is the end of the presentation. And I think we now have about 10 minutes to answer any additional questions that have not been covered in the panel. Now, I may actually turn to some of my colleagues who've been answering questions to see if there are any outstanding questions that need to be answered, or to one of the health department colleagues.
I'm not seeing anything outstanding in the Q&A box right this moment.
Okay, great.
If you have questions, go ahead and type them in to the quick Q&A box. Here's one. What is the recommendation for non-resistant CRS?
Hi, this is Katie Forsberg. I can answer that. So right now we're treating Candida auris the same regardless of what the drug resistance pattern was. I can tell you for the Northeast, Mid-Atlantic regions in general, it's very rare that we see anything but pretty highly resistant C. auris. There are some regions in the country that have more susceptible C. auris. It does seem to be region specific. This is getting into the details a little bit, but there's different clades of C. auris. There maybe have something to do with the clades. So we do see different resistance patterns throughout the country. And in your region, like I showed, there is high resistance. But regardless, even if you found a C. auris that was not drug resistant, we're currently treating it the same way, in part because you can develop resistance while on treatment. And we've seen that you can, of course, spread C. auris to other people after that as well.
Okay, and I think some of this might have been covered, but can you talk about C. auris persistence in the environment?
Yes, I can talk about that too. Yeah, Candida auris, unfortunately, it contaminates the environment a lot. There's been numerous tests looking at C. auris all over patient and residents' rooms. And basically what we've seen is if you have somebody who has C. auris, it's going to be in the environment and probably a lot of places in the environment. And when we do laboratory testing, we can see that it lasts on surfaces for at least 28 days. So we know it can persist for a long time in the environment if proper cleaning and disinfection is not performed.